All right. Hi. Thanks for joining us
Hey,
in another COVID update. I'm here with my friends Farid Jalali and Salim Reze. Um, both, especially Salim, caught in a huge tidal wave of the second wave. Mine, I was just saying, was a bit more like a rising tide. And Farid's been fighting a huge battle to really dig deep into the pathogenesis of COVID-19 and some aspects that, at least in the first few months were overlooked and are now starting to gain some traction. So that's what we're here to talk about and discuss today, guys. The sort of we can't even say beaten path, but off the initial path type of approaches and what's the data surrounding it, because there's no big studies that have come out on any of this stuff, but interesting anecdotes and interesting pathophysiological explanations, and I'm glad to learn from you guys today.
hey, thanks for having me. Let's just, jump right into it. Um, so in terms of COVID-19, seems like the virus gets into the alveolar space, um, uses the ACE2 receptor to get into the type 2 pneumocytes, cause pneumocyte injury. And the parasites, which are kind of smooth muscle equivalent of capillaries in the lungs, they seem to be damaged with the virus through the ACE2 receptors. This results in the virus getting access to the endothelium and the alveolar capillaries, and the parasite loss seems to cause the endothelium of the lung capillaries to become unstable. Once it gets into the alveolar capillaries, you have the classic diffuse alveolar damage, which means you have some alveolar damage, some endothelial damage. And the kind of the unique part about this virus is it seems to activate platelets and megakaryocytes more so than other pathogens. And there's a thought process that CD147 or some other receptors lead to kind of overactivation of platelets and megakaryocytes. The receptor affinities for this virus, the ACE2, kind of allows it to, cross all these layers very efficiently. And then possibly that CD147, causes the platelets and megakaryocytes in the lungs to become superactive. This is a slide that shows the parasites loss in the COVID lung. And this has been even mentioned in the New England Journal of Medicine pathology study on COVID-19. When you lose your parasites, it's been shown over and over again, not just in lungs, but in brain and other areas. You lose the barrier function of the vessel wall, so the virus can kind of get inside much easier. And parasites are necessary to maintain a stable lung endothelium. Lungs are a site of platelet production. It's been shown that 50% of platelet production in the body occurs in the lungs, and you have a bunch of platelets sitting, just residing in the lung vasculature, and a bunch of platelets and proplatelets and megakaryocytes sitting in the lung interstitium. SARS-CoV-2 has CD147 affinity. CD147, as shown in this slide, binds platelets. There's not a whole lot of ACE2 receptors on platelets, but there is, numerous CD147, possibly other receptors on the platelets that this virus binds to. And this is a study that shows CD147 activates megakaryocytes and platelets. And in terms of platelets in ARDS, this is a very good article to read. I recommend, most people to kind of take a look at it. There is this thought process that platelets are completely protective when, activated by pathogens. They act not just as thrombotic, cells, but they act mainly in an immune fashion to kind of get rid of pathogens in the lungs. There's also this thought process, and there's evidence, plenty of animal evidence, that overactive platelet activation in the lungs can lead to tissue injury. And this article, goes into great details describing all these, studies and how antiplatelets of different kinds have helped in many, animal models. So again, platelets are activated in ARDS of microbial and non-microbial causes. They can become, this response is protective for the most part, but it also can lead to tissue injury. And you have to separate the thrombotic action of platelets from its immune action. Simple antiplatelets that we have may get rid of the thrombotic possibilities, but they may not modulate the immune action of platelets. We're scratching the surface on the immune function of platelets at this point. Now, can a viral pathogen result in a heightened state of platelet activation? Yes, plenty of them do. Influenza does, dengue does, all sorts of, pathogens, especially viruses, are detected by platelets and, lead to activation to protect the host for the most part. Does every pathogen access the same kind of reservoir of platelets in the body? No. Dengue is a mosquito bite, gets into your circulation, and primarily interacts with circulating platelets and immune cells. If you have a pathogen that's just super good at getting to the lung reservoir of platelets, such as COVID, then sure, of course, this virus is going to do what it's going to do. It's going to activate platelets there, and that's probably what's happening, in this disease, among many other things that are happening. Has SARS-CoV-2 been shown to cause heightened platelet activation? Yes. I'm gonna pause here. There is 4 really high quality studies. There is plenty more, average quality, lesser quality studies. I've named some of them here. They're published in very, high ranking journals. Over and over and over again, it's been shown that, SARS-CoV-2 causes a heightened state of platelet activation. Some of these studies compare to sepsis. Some of these studies compare to other inpatient people that are admitted for other reasons. We have unpublished data from the first group that I worked with that compared non-COVID ARDS versus COVID ARDS, and there's a significantly higher degree of platelet activation. There's a preprint that shows the same thing. It's on MedRx IV from an Irish group. There is another study that came out recently comparing sepsis versus COVID-19, and there is vastly different thrombotic and fibrinolytic profiles between sepsis and COVID ARDS. So there seems to be some extra level of platelet activation in this disease. And that's kind of what I went over in this slide. And if you look at the TEG studies, despite therapeutic anticoagulation, patients remain hypercoagulable. This is kind of the heparin resistance that people keep talking about. And the parameters on the TEG suggest a significant hypercoagulable effect from platelet activity and fibrin. Am I smart enough to tell you exactly what that, how they, come up with that? No, but over and over in several studies, on therapeutic anticoagulation, they're seeing TEGs that are still hypercoagulable, and seems like the parameters are related to fibrin and platelets. So there seems to be something going on with extra, hot, overzealous platelets in this disease. Do we know how this virus causes heightened platelet activation? I think it's multimodal, and it's up for debate, and lots of smart people are working on it. I think part of it is the virus efficiently gets to the lung platelets and megakaryocytes by kind of crossing every barrier that I just showed you efficiently with ACE2 and this and that. I think there's some direct viral activation with CD147. It's been shown to activate platelets, and this virus has been shown to have that receptor affinity. There's a new study that came out, and it's kind of suggesting that there may be some molecular mimicry activating platelets and megakaryocytes. And lastly, there is a very prominent study out of Michigan showing autoantibodies that activate platelets and platelet leukocyte aggregates. They've actually, collected these autoantibodies from patients with COVID and injected it into mice, and it caused thrombosis without nothing else added, essentially. And I've kind of included the references for these things. I think the first and second step are pretty quick. The virus gets to your lung platelets and megakaryocytes, activates them to some degree. Then the molecular mimicry might take some time to kind of cause its effect. And then the autoantibodies not only depend on some extra time, but also on the host response, depending on how active your own immune system is to kind of, embark upon this autoantibody destruction of platelets and activation of platelets. This is a study out of Lance. I think it was one of the Nature journals that came out. The top part is the spike glycoprotein for SARS-2. All these other lines that I have here, coagulation factor X, platelet endothelial aggregation, von Willebrand factor, and it shows the similarity between the protein motifs with spike protein of SARS up top and the rest of them. There seems to be some molecular mimicry where, I guess your body decides to, attack the spike protein, which is up top, but then these autoantibodies seem to also activate or at least interact with von Willebrand factor and other, coagulation factors. So, kind of getting into the practical stuff, why does all of this matter? Severe infection with COVID has hallmark features of altered megakaryocyte number and function. There was a recent study that went over this, German study that went over this in great detail. And altered megakaryocyte number and function was the only thing that really separated the surviving versus non-surviving severe COVID-19. They talk about all these interferon response and dysregulated interferon, this and that. None of that separated the survivors versus non-survivors. It just said you're going to have severe disease. But then once they dig deep into that group, they realize that it's the altered megakaryocyte number and function toward a pro-aggregating kind of phenotype. Again, over and over again shown this disease causes heightened platelet activation, heightened platelet degranulation, netosis, platelet leukocyte aggregates. It causes heightened endothelial activation. And at the end of the day, after all of this is really heightened and really overactive, you're going to get a bunch of thrombi, which also has been shown to be more prominent in COVID-19, not just systemically, but also in the lungs. There seems to be higher dead space. The first 5 lines are, in my mind, these are all immune functions of the platelets. And the last one is the thrombotic. And, how do we deal with immune function of platelets? Hard to tell. I mean, what's the best target? It's not clear. Do steroids work on immune function of platelets? There seems to be one study that shows prednisolone, reduces immune function of platelets. But we simply don't know. Are we targeting the immune function of platelets by adding steroids, among other things that steroids do? Possible. It's just not clear. But some of the targets in kind of here in this slide, to reduce platelet activation, aspirin, Plavix, dipyramidol, baricitinib. I read the kind of the landmark study on that, and if you look at even the abstract, it talks about how it dampened the platelet response. How do we, really, reduce platelet degranulation? We'll talk about that in a little bit, but SSRIs possibly, or serotonin antagonism, among many other things that platelets release. Those two, in my mind, may be very important. How do we reduce platelet leukocyte aggregates? Again, dipyramidol. How do we reduce endothelial activation? Heparin. Not only has antithrombotic effect, but also stabilizes, endothelium by avoiding VILI, ventilator-induced lung injury. And then obviously trials on statins, defibrotide, other things. And at the end of the day, how do we reduce thrombi formation? Well, you have the heparins and the anticoagulants and for that. And I think you kind of have to address a lot of these lines here to kind of have an effective response against the platelet activation of this disease that seems to cause some carnage for severe cases. It's important to kind of realize that pulmonary endothelium activation is not, it's not kind of in its own little box there, and it has interactions with platelets. When the endothelium is activated, platelets are activated. Vice versa, when you have platelet activation in the pulmonary capillaries, then the endothelium of the pulmonary vessels are activated. There's a very direct correlation there, shown in many, many studies. And mediators from platelet granule release drive a large portion of protection versus pathology again, in many types of ARDS, as shown in the previous article that I cited. I highly recommend people to read that. And these platelet mediators have to be curtailed in some fashion if the disease is causing overactive platelet activation. And lastly, the thrombi that are formed, to me, they're just kind of an end result of a very biologically active kind of cascade of platelet activation. They're not the pathology, they're just the end result that we sometimes detect on CT angiogram and we see it on autopsies. But, just to get rid of the thrombi does not mean you've dealt with the platelets and the platelet mediators. And that's the message I want to focus on here. So I've kind of made this little diagram to kind of talk about that. And in the middle you have a box with like hugely interdependent platelets and endothelium in the lungs. One, the virus activates platelets. Platelets activate the pulmonary endothelium. The virus also destabilizes the pulmonary endothelium with the parasite loss. And this box kind of just runs back and forth, back and forth, back and forth, just activating itself. And if you have a large inoculum of the virus, if you have a bunch of lung areas that are going through this, well, I mean, it's going to be problematic to some degree. Then you have, on one hand, you form platelet leukocyte aggregates, and those end up causing thrombi, which we see. And then on the left side, you have platelet mediators. They are being released, whether you like it or not, they're there. Some of that stuff is very biologically active, and it is something to consider. And then on the bottom, you have kind of the lung alveolar hyperdistension process, where essentially causes ventilator-induced lung injury, not just to the alveoli, but also the pulmonary capillaries in those alveoli that are hyperdistended. They're going to be activated. It's been shown over and over again, if you look at ARDS studies, that if you use, let's say, a high tidal volume, or if you hyperdistend your alveoli, endothelium of that alveolus gets activated, platelets get activated. I can cite the studies for you guys, but there's not a question there that villi is not just an alveolar injury, but it's probably more so an endothelial injury, the alveolar injury itself. So you kind of have to think of this disease being so angiocentric and vascularly mediated. In my mind, all of this kind of slide has to be considered if you want to approach it with the right mindset and treat it the right way.
Farid, can I stop you? Farid, can I stop you for 1 second? So I think that's a really important point about this being a vascular disease. And I'm so glad we have smart people like you that can break down granular details of things. But at the end of the day, I'm a clinician that takes care of patients. And, when we talk about risk factors for who's going to get severe COVID, we talk about older age, diabetes, hypertension, hyperlipidemia, smokers, coronary artery disease, obesity. And for the longest time, I was trying to put all this together. And the point that I want to make here is, as you're going through this granular detail, is that the thing that all these patients have in common is they have pre-existing vascular dysfunction and altered endothelial cell metabolism. So their vascular beds are sicker than people who don't have these things. And so I think that's the point you're getting at, is that their endothelium's not going to do as well. It's a vascular disease. It's going to activate their platelets. And then I'll let you kind of continue, and then we'll talk about what we do with that clinically. And please, if I said something that's incorrect, always feel free to correct me.
No, absolutely. You're absolutely correct. One study that just came out a few days ago, it showed that as you age, you end up having a lot more of these CD147 receptors on your platelets and other immune cells. So again, could that be a reason why older people are having far more severe courses, and possibly more platelet activation that leads to this. So again, I kind of gone, in terms of practical stuff, I'll go over how some of the therapies we're doing are affecting, in my mind, this box, which I think is very, very important, not to take away from all sorts of other aspects of this disease, but I think this is probably a central box of this disease, we have to consider. Antivirals, I kind of put a little green box with a check mark. I guess if you, give them early enough, which is hard to do, they kind of reduce the activation to platelets and to endothelium being contributed by that, virus itself. Antiplatelets, well, I mean, if we know which antiplatelet to use to reduce the immune function of platelets, which is it's not a clear thing, I get kind of private messages from people after I tweet, well, folks should take an aspirin or whatever. I get some private messages from these hardcore platelet biologists who are saying, listen, it's not that easy. I mean, if it was aspirin, we would tell you, but not all immune function of platelets are, curtailed by aspirin. It just focuses on COX-1, but you have a bunch of other mediators, and they're correct. They're most likely correct that we simply don't know how to curtail the immune function of platelets. But, presumably if we knew, then you kind of target the middle box. Platelets are less active, endothelium will be less active. And then the thrombi that are forming in the bottom right, I guess you're going to have less thrombi forming, but it's not going to change the existing ones. You're not going to get rid of the existing ones, when the patient shows up on day 10 of the disease and has a bunch of clots. And I guess you're going to take care of the platelet mediators to some degree, but probably not enough. Dipyramidol is kind of a weaker antiplatelet, but its effect is mostly on reducing platelet neutrophil aggregates. It's being trialed in University of Michigan. I know they've enrolled quite a bit of patients. They're still waiting on the results, to publish, but this is kind of where dipyramidol focuses. It adds the platelet leukocyte aggregate, to the mix here. This is one slide I want to focus on because I think there's very recently, a study came out of Sweden saying patients that had been on DOACs did not necessarily do better in terms of COVID-19. And I know early on in New York City and other places, they would just send people home on Eliquis or Xarelto and, and say, bye-bye and hope you do very well. But as we know, some of those patients showed up, back to the hospital and didn't do very well. To me, DOACs focus on the right side. They get rid of the thrombi that are formed, possibly the existing ones and the ones that are being formed, but they almost do nothing for the rest of this picture. They are not antiplatelets. They don't stabilize the endothelium. They don't do anything for platelet mediators. They don't do anything for platelet leukocyte aggregates. They just reduce the burden of thrombi. In my mind, the disease is run and driven by platelets and platelet mediators as opposed to just the thrombi. We've all seen patients who've been on Coumadin or other things show up still very sick to the hospital. I mean, there has to be an explanation why, Compare that with heparin. There's many studies that show heparin has endothelial stabilizing effect. And if you kind of address the endothelium in the middle, the perpetual kind of feed forward activation of platelets is somewhat controlled. If you have something that stabilizes the endothelium, potentially you could have, kind of less platelet activity being fed off of that activated endothelium. Heparin also addresses the right side. It reduces the existing thrombi and the forming thrombi. And because it reduces platelet activation, most likely it reduces platelet activation, at least it doesn't allow it to perpetually kind of get worse. You probably are dealing a little bit with platelet mediators as well. This is if you start heparin early enough in somebody who seems to have, symptomatic COVID, maybe day 5, 6, 7 or whatnot. Nobody knows what the right time is, but there seems to be a response, to heparin products. Heparin plus an antiplatelet, again, we're getting into scary business here, risk of bleeding, this and that. In my mind, it's only going to help, but again, who knows what the right antiplatelet here is. It may not be one of those antiplatelets that necessarily just works on the thrombotic action of platelets, but it may be an antiplatelet somehow that reduces the immune function, and the choice is unclear here. And then when you have heparin, antiplatelet, and lung protective ventilation, well, you also deal with the villi down there. And I think this is where, potentially where we save patients, is addressing almost all of this box, except the antiviral part, which is hard to address because by the time patients show up, it's kind of too late to give them any antiviral that helps. Now, this is the scenario that worries me is, if they're a late presenter and they come on DOACs from home, you've dealt with the right-hand part, the thrombi, everything else is not dealt with. You're gonna have a situation where you have really hot platelets running around with a bunch of meters that have soaked up the lung and they're just sitting in the lung interstitium and nobody knows what to do with them. But hey, there's no thrombi, but everything else is gonna be there. The effects of these platelet meters are still gonna, be pretty significant on the lung. And then this is kind of the scenario that I see every day, at least looking from the side. I don't manage these patients actively. They're kind of late presenter. Most patients are late presenters. As the pandemic gets worse, they're not going to be admitted, Chris Christie style or Donald Trump style. They're going to be coming in, day 10 or whatever. And you have them on heparin and lung protective ventilation. There's a high burden of thrombi. You're dealing with it. There's a forming thrombi, you're dealing with it on the right. The heparin is kind of dealing with the platelet and endothelium. It's kind of playing a little catch up in my mind. There's a high burden of platelet mediators on the left-hand side. Day 2, less burden overall, but you're still playing catch up on the platelet mediators that have accumulated there in my mind, at least in some patients. Day 3, same process. You're kind of just helping them, move along until the platelet activation from this virus goes away, which we know is not forever. The studies that are unpublished, the platelet activation definitely does not last beyond 8 weeks. And there is a thought process, it may be 2 or 3 weeks. And that may be the length of time we're keeping these people on ECMO or whatever we're doing. We're just buying time until their platelets are like, okay, we're done doing what we're doing, we can all relax now. And, kind of like as the days progress, you're kind of dealing with a lot of this stuff on the right-hand side and in the middle, but potentially there will be a subset of patients, where the platelet mediators are still pretty, significantly in the patient. And let's say you end up using a high peak now, or whatever ventilation modality you're using that leads to more villi, more hyperdistended alveoli. Then all of a sudden in the bottom box, we're activating the endothelium. And then you go back into this kind of vicious cascade of just activated endothelium, then activated platelets, and you're almost taking 2 steps back. That's why, it's obviously this is your expertise, but it's best not to mess up with the pulmonary endothelium by causing hyperdistended alveoli in these patients. And lastly, I think this is where I see some of the patients, and this is what I want to talk about. You have a bunch of people on heparin who, they're kind of doing well. The thrombi are probably reducing, the D dimer is going down, and, not a whole lot else in the middle is that important to the clinician in front of you, but you might have a clinical problem on the left side with these platelet mediators. And most of these platelet mediators are not evident to us, but one of them potentially might be. That might just accumulate in the body. These are platelet mediators in the body. There's plenty of them. These are some of the ones we can target: serotonin, histamine, complement factors, P-selected inhibitors, integrin inhibitors, platelet factor 4, TGF-beta. The rest of them, we don't even know what to do with. I don't think we have any idea how to inhibit a lot of these things. To me, serotonin is unique. 95% of total body serotonin is tightly kept in platelet granules, and florid release of serotonin from hyperreactive platelets and megakaryocytes occurs in COVID-19. There's data on that. once you have a bunch of serotonin released in the body, which happens not just in this disease, but other platelet activating disease, heparin-induced thrombocytopenia is another one. There's plenty of other disorders that do this. Once you have a bunch of serotonin released, you depend on a healthy pulmonary endothelium to reuptake it. In one circulation, in one pass, let's say you have a bunch of serotonin released because your leg got crushed and there's a bunch of thrombi forming, then in one pass, after it passes through pulmonary circulation, 80 to 90% of that is reuptake into the, by the lung endothelium, and it's loaded back onto the platelets. And this is where the regulation of platelet serotonin happens. Now, it's a hard commodity in severe COVID-19. This healthy pulmonary endothelium is not going to be there because of the disease. And if you happen to cause hyperdistended alveoli, the healthy alveoli that you have, if they're hyperdistended because of overzealous PEEP or whatever else that you have, then those healthy alveoli endothelium are also not happy and they're not healthy to reuptake the serotonin. So you have a situation where the injured ones are not doing their job, the healthy ones probably are briefly not doing their job, and you have serotonin release, but little reuptake, and the serotonin is going to build up. This is a study that shows exactly that. This is the plasma serotonin in the bottom. The blue is healthy people. It's kept at a very low level because that's what we do. We keep the serotonin in the plasma at a very low level because free serotonin is pathologic. And then in COVID-19, you see the numbers there. These are not normal numbers. And if you look on the left-hand side, the platelet content of serotonin in the healthy people, it's high. And then in COVID, it's lower and lower, especially in severe COVID, which tells you there's a translocation of serotonin from platelets into the plasma. And that's not healthy. That is pathologic. Now, has this been shown in other studies? Yes, I didn't cite it here, but there's at least one or two more studies that I read where the serotonin levels are increased in COVID-19 cases, but this is probably the most clear one that measures it. And what could extra serotonin in the body do? These are all the signs of serotonin syndrome and serotonin excess. There's 60,000 publications on COVID-19. I think I might have read maybe 10,000 of them so far in the last 8-9 months. And anecdotally and from published stuff, I put a star next to the ones that I've seen myself, or at least I've read about it. These are all the things that have been reported in COVID-19, which I don't know, you guys see more ARDS, patients with influenza and other things. Do you see a lot of these things in regular ARDS, flu or whatnot?
Well, obviously, anytime you have someone who's, critically ill, intubated in an ICU, there's many of these things that it's just hard to discern if they're just, part of the disease or part of the experience. You're going to be tachycardic, you're going to be restless, you have a tube in your throat, you can't move, you're anxious, maybe diaphoretic. So a lot of especially the neuro stuff is really hard to identify as being anything. And then anytime you've got anyone with a whole body injury, like any viral thing, then you often have elevation of organ specific enzymes, liver function test, creatinine, a lot of those things. So it's tough to say, but obviously I think we've seen many of these things in COVID.
Can I say one thing so I agree with Philippe. You see all these things in critical illness, but the one that I want to kind of point out is inducible clonus. I don't see inducible clonus in patients who are sick with ARDS. Yes, you see tachycardia, you see tachypnea, you see elevated blood pressure, you see delirium. You can see all these things with a really sick patient in the ICU, but inducible clonus you don't see.
Right. And I think out of an article from New England Journal and then a couple other ones, there's in severe COVID, they cited 67%, hyperreflexia and clonus. again, I'm not a critical care doctor, but I think those are pretty specific signs for serotonin excess. It may be other things that cause it too, but that is a high number. And I don't know if it's still that high. This might have been early on in the pandemic where, some of this may have not been managed well, who knows, but, so in terms of plasma serotonin excess, these are the ways I think about it, and there's plenty of literature supporting that this is what happens. In COVID-19 patients, at least in a subset, there's an inappropriate hyperapnea. They're breathing more rapidly and possibly more forcefully, and they're driving their PaCO2s down for whatever reason. I see people from periphery. I look at their ABGs all the time, and I'm like, what's going on with this PaCO2 of 25? I don't know, Philippe. What do you think? I mean, what's caught? Go ahead. Tell me what your thoughts are.
I always go back to a conversation, as many of you know, and Rory had COVID in the first wave, and obviously equipped with a fair bit of knowledge and a sat meter, and he says he was feeling lousy, and at one point developed this irresistible urge to breathe, and fortunately for him, it just, I think, lasted a night or something like that. But he checks his saturation, he's feeling okay, sat is fine, but he had this urge to breathe, no difficulty breathing, but just sort of something that really seemed to be central in a sense, and that's what that rings a bell about. Obviously, the patients I've had many of the times are not able to provide that type of history, and we don't have the whole oxygen sat data along with it, but that's possible. And we also see here in this slide, one thing that was, we've never done as much dialysis as we did during the COVID. So that reduced renal blood flow is interesting, and it obviously pulls me back to my point of care stuff, and now I'm going to be tempted to look at that more specifically. So lots of interesting stuff in there.
Yeah, so again, the things kind of I've seen, from the periphery, again, the hyperapnea, it's puzzling me. It's puzzled everybody from the beginning of the pandemic. What's going on there? Reduce, so I wouldn't say reduce renal blood flow, but we all see AKIs, as you said, dialysis, and I look at their parameters. I look at their blood pressure. There is no pressure requirements. The systolics, diastolics map. Everything seems fine. There seems to be no renally toxic medications going on, but next thing you know, they have an AKI for no clear reason. The agitation, the hallucinations, I've seen them, they're very common, out of the blue, with no severe metabolic derangement and no severe hypoxia. I mean, yes, they're on high flow, but they're satting like 91, 85, and they seem to have this hyperactive delirium, agitated, hallucinating. Unfortunately, I think I heard about one patient even hanging themselves in the hospital bed with no prior psych history at all, 0, and died from that. The myoclonus, the hyperreflexia, again, cited to be 67% in severe COVID, at least early on in the pandemic. All of these are, associated with elevated, 5-HT, serotonin in the plasma. And, obviously it can cause tachycardia, it can cause bradycardia, arrhythmias. It definitely has been shown to cause peripheral vasoplegia, in animal models. So possibly could that be the little low-grade shock that people sometimes have? Hard to tell. Febrile episodes, very common with serotonin syndrome. These people spike really high fevers for no clear reason that we can think of, despite being on antibiotics and other things. And not necessarily early on in the disease. This might be day 10 or day 14. All of a sudden they have a fever of 102, 104. Severe diarrhea, again, not that important, but it's been reported many times. And, going back to the hyperapnea, this is a study. There's many other studies that you can look at, but this is one that kind of summarized everything. On the left, you have COVID serotonin that's elevated. And in this study, they looked at application of serotonin to the carotid body, carotid sinus. And on the right-hand side, you have the phrenic nerve activity. And those are basically these rapid, strong respirations, that occur after you apply serotonin to the carotid sinus, carotid body. And this is the little caption in the bottom where it talks about how serotonin causes augmentation of phrenic nerve activity. That is hyperapnea, essentially. Is it happening in COVID-19? Is this the only mechanism? God knows. But could it cause it? Of course, it could cause it. And lastly, back to practical stuff. How can we prevent this serotoninopathy? Again, back to the same slide as before. Early treatment better than late. If you let it accumulate, if the platelets are just hyperactive, releasing a bunch of stuff, and you kind of catch the patient really late, and you're dealing with the thrombi, you throw anticoagulants. Early on, people will do TPA. They'll clear all the clots. The patient still dies. It's because these platelet mediators are causing a lot of havoc for the patient. One of which that's very active is serotonin. So you reduce platelet activation. Which choice of antiplatelet? God knows. Again, heparin, avoid villi, all sorts of stuff. The thing I want to talk about is, could you modulate this serotoninopathy that seems to exist based on data? At least the measurements in the plasma and clinical signs are there. Could you modulate that and possibly improve outcomes? It's a very big question. It's a very, the answer is not clear. You can either reduce the bioavailable platelet serotonin content in the body, which is stored in the platelets. 95% of the serotonin is stored in platelets. How do you deplete the platelets from serotonin? How do you deplete serotonin from platelets? SSRIs, chronic SSRIs can do that. Do we have a couple studies retrospectively showing that people on SSRIs have less severe COVID-19? Yes, there are studies showing that. Do we have a trial, randomized controlled trial, double-blind on early SSRI administered to patients with COVID-19? Yes, it came out of JAMA. I think Salim went over it. It had promising results. Now, platelet lifespan is 10 to 12 days. SSRIs probably take, I don't know, about 2 weeks to deplete platelet serotonin. In animal studies, they usually use 2 to 3 weeks of, let's say, a high dose SSRIs before they test the serotonin aspect of platelets. Is it plausible that that randomized controlled trial out of JAMA could potentially be something promising if started really early for acute COVID patients? It's possible. If you don't do that, and if you don't have the patient chronically on SSRIs, and you have a case of serotonin excess that's clinically evident, causing some of these symptoms, that you're seeing in front of you, could you antagonize that excess serotonin that's in the plasma? You're doing all the antiplatelets, you're doing the heparin, you're trying to kind of just make this mess a little bit better for the patient, but you might have a lot of excess serotonin just built up, causing issues for the patient. Could you antagonize it? Cyproheptadine is mainly a 5-HT2 antagonist, along with an antihistamine, has some sedative side effects, obviously. And it's effective in serotonin syndrome to some degree. It's not a magic solution, but it does work. So that is one way to get rid of the excess serotonin action on at least 5-HT2, which seems to mediate a lot of the neurologic stuff, some of the renal stuff. A lot of these side effects are 5-HT2 mediated. Precedex has been used in serotonin syndrome, has some 5-HT antagonism. And then lastly, avoid serotonergic medications in ICU that could potentially make this process with excess serotonin a little bit less bad for the patient. What are the serotonergic medications in ICU? Again, I kind of just made a little table on the right. The one that bothers me the most is fentanyl. And I don't know if it's fentanyl interacting with some of these serotonergic medications, or is it on its own, potentially has a little serotonergic, property, but it's definitely cited as worsening serotonin syndrome or worsening serotonergic toxicity for patients. There's a pre-COVID ICU delirium study that looked at unrecognized serotonin syndrome in ICU delirium. And the number one culprit was fentanyl, obviously with other things, including tramadol and other medications. I have no idea if this is possibly worsening some of the serotonergic side effects of COVID-19, or it has no effect, who knows. And lastly, I'm including Vili as a medication that's serotonergic. Again, I firmly believe that if you hyperdistend whatever little healthy alveoli you have left in these patients, you're going to have less reuptake of serotonin, less ability to regulate the serotonin in these patients. And to me, that's a serotonergic medication on its own. We have to think about not just the gas exchange function of the lungs, but also the biologic function of the lungs. And one of the most prominent biologic functions of the lung vasculature is to regulate serotonin. And with that, I think I've gone over everything I wanted to go over. But I'd love to hear from you guys what your thoughts are.
Just quickly, in the serotonin modulation you're talking about, and this is SSRIs, and these are not my cup of tea. So you've got the SSRIs both on the possibly agents to reduce the pool of bioavailable. Obviously, there's a time lag to that, but you also have them as a serotonergic.
Yes.
So
and that's scary. That's scary to me because of the randomized trial out of WashU saying early serotonin, early SSRI use. As with everything else in this disease, I think the timing matters very importantly. If I was a sick, severe COVID patient in the ICU and somebody said, hey, let me try an SSRI on you because of this trial, I would say no, especially if I have any of these signs, of serotonin excess. Now, could an very early SSRI deplete platelet serotonin and at least deal with the serotonopathy of severe COVID? It could, if it's early enough. And you still don't have a bunch of these kind of platelet mediators build up, it's possible you could at least deal with the left side of this diagram. Is the SSRI dealing with the rest of this diagram? I don't think so. Do we have patients on SSRIs who are in the ICU dying chronically on SSRIs? Yes, I've seen them. I think you guys have seen them. So is it dealing with the whole box here? Absolutely not. Is it dealing with the left side? Yeah, it probably is if it started early enough.
Philippe, the way I had reconciled that was that people who are on chronic SSRIs don't have hyperactivated platelets because we're catching them as outpatients, whereas patients we're seeing in the hospital are already hyperactivated. And so the SSRI could potentially make that worse, could amplify that. At least that's the way in my head I had worked that. Whether that's actually the case or not, I don't know. But the more important point, and the thing I've been seeing on social media and people talking about is, oh, we should be putting all these patients on SSRIs. And I'm with Farid. That was an outpatient study of patients who were on SSRIs chronically who caught COVID, not patients who got COVID, were sick in the ICU, and then got put on SSRIs. So it's a key distinction.
Right. Yeah. Totally agree. I mean, I think timing is everything, and I don't know what's happening, in your local places, but remdesivir has just come around to our hospital, and it's for the sicker patients, and I'm like, just mechanistically, how's that going to work? You're going to try to if any antiviral is going to work, it's going to work when you're up on you're climbing part of your viral load, to keep it down. If you're already, on high flow on the ward or in the ICU, I think that you've missed the boat with the remdesivir completely.
Yeah.
So the timing is going to be really, really important in all these things.
Absolutely.
Expensive Tamiflu, Philippe. That's what remdesivir is.
Yeah. Sounds like it's really useful for maybe a corporate aspect more than anything else at that point. But I mean, if it was at the first sign of a first time of fever or anosmia, you took it, and maybe then.
Yeah.
I have, I know we don't know the answer to this, but the answers are coming. One of the medications that Farid talked about was dipyridamole. And I have a lot of interest in that medication because it does a lot of things. It's an antiplatelet, it's an anti-inflammatory, it can also be a vasodilator. And now there's some evidence that maybe it binds to SARS-CoV-2, like the M protease, if I remember reading correctly, which can suppress viral replication. And so it has all these factors, and there's two papers that are actually in recruitment right now. And hopefully by early 2021, we'll have some answers on this. One is the Dicer trial. I believe it's like 80 patients, and they're going to put people on dipyridamole 100 milligrams QID versus placebo. And the second one, which I'm more excited about, is the ATAC-19 trial, which is actually going to look at dipyridamole with aspirin, a combination. And their primary outcome is their COVID-19 ordinal scale, the one that we all get frustrated with. But some of their secondary outcomes are mortality, supplemental oxygen, and need for invasive mechanical ventilation. So just wanted to mention those to people that be on the lookout. But I find this to be a very fascinating medication because it actually could serve multiple purposes, much more than just aspirin alone.
Yeah, that's really, and that's what one of the thoughts I had as Farid, going through this amazing presentation. I'm almost worried that these individual trials hitting one little branch, one little arm of these graphs may not have marked effects, and what you'd almost need platelet cocktail, to stop all these little branches and to really see the impact. I just hope it doesn't take too long for someone to get around to do that.
And then the second point I want to bring up is this serotonin excess clinically. And I had kind of alluded to this about clinical signs. And I'm with you, Philippe. I think it's really hard to differentiate, somebody who's got flu versus, some other viral pneumonia compared to COVID-19 from a clinical standpoint of like tachycardia, tachypnea, all these sorts of things. There's a huge overlap. And so I don't know how you like put those into a different box. But the one thing that caught my attention is Farid is quoting a paper out of New England Journal of Medicine. I think it was like 60 patients, and they had inducible clonus, corticospinal tracts, in like 2/3 of the patients. And there's subsequently been another publication in Critical Care that looked at 140 patients, and almost just over 50% had corticospinal tracts based out of France. And so now I've been trying to walk around and see if patients have ankle clonus when I'm walking around. And I'm just kind of looking for that because to me, that's a sign of pretty specific to serotonin excess. And so that's why I kind of alluded to that. And we can talk about what I do about that. It's one thing to be able to identify it. It's another thing to actually treat it. But I do want to point that out, that amongst all those things that Farid brought up, you can just see that in just usual critical illness. All these things can be seen in usual critical illness, but inducible clonus is very specific.
Yeah, that's certainly going to make me go around and do more of that. I remember I'd put up a little video clip about a patient who had a neurological injury, who had really marked myoclonus, inducible clonus. But I can't say that it's something that I routinely do on all intubated patients in the ICU every day, but I will now, and those are high numbers.
Yeah, again, pre-COVID ICU delirium, 16% were later on diagnosed with serotonin toxicity. That's not a small number pre-COVID, and I think COVID, again, I don't want to say it's unique because that's not a very popular word to say among academic circles, but it causes more pulmonary vasculopathy and it causes a higher degree of platelet degranulation. I don't think those are debatable anymore. Maybe 6 months ago when we were talking about it, people were like, no, I don't think you're right. But, the pulmonary vasculopathy has been shown over and over again in, pathology studies, in clinical studies, in measurements of endothelial kind of markers that are released in the plasma. And then the platelet degranulation, I don't think there's much debate on that, in terms of numerous studies that have come out. So if you have 95% of your serotonin inside platelets, and these are degranulating, and if you rely on a healthy pulmonary vasculature to clear it up, but that healthy pulmonary vasculature is much less, present, then the answer is clear. You're going to have a higher degree than the 16% you saw with pre-COVID ICU delirium patients. Maybe it's 20, maybe it's 25, but it is a process in my mind that confuses people. I see my own ICU attendings. They're like, oh, I have no idea why this guy is thrashing around and kicking and screaming, and he's not even intubated. His oxygen is not that bad, but he's just hallucinating, and is just breathing 37 times per minute, causing a PaCO2 of like 25. But their oxygen levels are really not that bad. I mean, I hear them talk about it. I see the patient's charts and whatnot. And sometimes the answer is, I don't know, put them on Precedex, put them on some, sedative, do something, give them Haldol, give them risperidone. And next thing you know, well, patient's not really responding well, let's intubate, and I think that's a cycle that could be avoided in, even if it's 16% of patients, which is pre-COVID ICU delirium. I think it's probably a little bit more than that. But if that cycle could be avoided, potentially we could have less patients ending up in the ICU on event, and the ramifications, that come with that. So that's why I wanted to just bring, this presentation to, to life, to kind of just talk about that. This is not a foreign concept. It's existed pre-COVID. It may just be a little bit more with COVID.
Yeah, and after several discussions that we'd had and reading, not the 10,000 that you've done, but a few. I did use cyproheptadine in a patient. Was it a couple weeks ago? A patient who was a COVID patient, obviously, who was in his 50s or 60s, and he wasn't saturating that badly. He was on a few liters nasal prong, and if he took them off, he went down to the 80s. And he was very confused, and he pulled out things. He wasn't aggressive. And if you told him, look, you're quite sick, and he was, had no pre-existing neurological issues, you've got to stay, but 5-6 minutes later, he was back at it, doing things and getting up and all these things. And, and after a couple of doses of cyproheptadine, by the next day, he was okay. And he ended up not doing that badly. Now, I'm not saying that's because of the cyproheptadine that I know of, but certainly his confusion seemed to have taken a radical turn. And I know you guys have anecdotally, used a couple of times. Do you mind sharing that experience?
Yeah. So for people who know me, do you think I work down in the ED, which I do, but over the last 6 months, I've been splitting my time up in the ICU and the ED because there's just a shortage of intensivists for the number of beds that we have. And I've had 4 patients that I've tried this cyproheptadine on. And before people start losing their minds, because I have seen people losing their minds on social media, toxicologists getting upset that we're doing this. We use cyproheptadine, antihistamine, anticholinergic type properties for serotonin syndrome commonly. And to me, this is mimicking serotonin syndrome in some patients, not all patients. And the thing that people get worried about is, well, this is not a benign medication. If you give it, you can sedate them too much. You can give them anticholinergic properties. And the thing that people need to remember, and like most things in toxicology, the evidence is rather weak. It's usually case reports and case series, not large randomized clinical trials. But the dosing for cyproheptadine in serotonin syndrome is 12 milligrams up front, and then 2 milligrams every 2 hours until resolution of symptoms. And what we've been doing is 4 milligrams by mouth 3 times a day for 24 to 48 hours. So it's nowhere even close to the dosing that we give for serotonin syndrome. And the 4 patients I've had, to be completely fair, I realize this is all anecdote, but I had 2 patients that were extubated, had recovered from their COVID, but still had a lot of agitation and delirium. And this is when I started checking for like clonus, and both of them had inducible clonus, ankle clonus. And so I started cyproheptadine, and by the next morning, Both of them were off their Precedex and any other sedating type medications and were like normal human beings. Two of the other ones that I tried this on, one was intubated and did have inducible clonus and ultimately ended up succumbing to their disease. And so again, want to be very careful about the way that I'm saying this. And then the fourth one was on non-invasive, also really agitated, had inducible clonus, put him on cipraheptadine, and basically didn't require any sedation, got him through the difficult period of non-invasive, and then ultimately ended up walking out of the hospital. So 3 out of 4 patients with inducible ankle clonus, I've tried cipraheptadine. 3 of them did very well within 24 hours. And the fourth one, unfortunately, I think it was probably too late. And no matter what I was going to do, they were going to succumb to their disease anyways. So that's been my experience with it.
Farid, any cases on your side or witness cases?
I witnessed one similar to what Salim mentioned. Guy very agitated, hallucinating, tachypnic, into the 30s. Again, this guy had 0 hypoxia. He didn't even require oxygen, nothing. And this was the reason that he got moved back from the telemetry back into the ICU. Is very tachypnic, hallucinating, agitated. I think urine output fell by a little bit. His creatinine and BUN were going up. CPK was 7,500. And he had hypotonicity. His muscles were a little bit weak. Obviously, I'm not frontline for these patients, so I didn't get to check clonus or anything else, but it was suggested that this could be serotonin excess, and the hospitalist kind of did his own research and looked into all the signs and different things. It started him on cipraheptadine for 24 hours. I think within 48 hours, he was out of the ICU. CPK went down from 7,500 to almost normal within 48 hours. Urine output picked up. Most importantly, he was breathing like 20 times per minute instead of 35. Nothing else was changed. 0 other changes to this guy's therapy. Again, may I remind you, he was on no oxygen at all. He was early on before he got moved back out of the ICU into the telemetry, and then he had recovered in terms of his hypoxia. But then he got moved back into the ICU with this kind of agitation, delirium, tachypnea. They were ready to essentially put him on drips and intubate him because they just couldn't control his agitation, hallucination, and tachypnea, and they thought he was going to tire out again. But again, no hypoxia. So, that's kind of what I saw. I definitely agree with Salim that this is not something you need to be continuing for 48, 72, 96 hours. Again, the one case I saw within 24, 36 hours completely melted away, and if you continue it beyond then, it might be a little bit sedative, and the patient, may have side effects from being overly sedated. But potentially for 24 hours, a few doses, I don't think there's much harm in it, particularly if a patient is already intubated. Airway protection is there, everything's there. Tachypnic, agitated, you can't get them under control in terms of sedation, which we hear all the time. I don't know, it's not the worst thing to try for 24 hours and see what, how they turn around and how the sedation requirements change.
The one thing I struggle with in these patients, you had talked about some serotonergic medications, with fentanyl being one of them. And, with all the kind of national drug shortages, you kind of get pigeonholed into what you can and can't use because you run out of one thing and you have to use something else. And so, in terms of analgesia for these patients, there was a period of time where my only choice was going to be fentanyl because we were running short on morphine and hydromorphone. Certainly ketamine is an option, but it's just, what do you do? Do you not give them analgesia, or do you kind of suffer the consequences of potentially potentiating that serotonin excess? I don't know the answer to the question, but that's one thing I've actually struggled with more so than the treatment of it with cipraheptadine.
Yeah, for sure. We used a ton of fentanyl in the first wave. Going to see about adjusting that a little bit. Lots of challenges. I mean, I think this really exemplifies we're in a fairly unique situation where there's a lot of data that's coming out everywhere. What do we listen to? And as clinicians at the bedside, when it's very easy for people, sitting behind a desk somewhere to say, well, you shouldn't be doing this. You have to wait until, all the evidence is in and whatever. But and there's a logic to that, of course. And in an ideal world, if all these studies could be done in the span of a month, and then we could, just wait till then. But who knows how long these things will take? And we, in the meantime, as bedsiders and not benchsiders, we have patients not doing well. And I'm sure, like you said, there's going to be criticism about, attempting to try some of these things that make biological sense. And that I think the ones that we do go ahead with, we feel strongly that the side effects or the downside to it is minimal. Which certainly I'm more comfortable, trying 24 hours of cyproheptadine versus just, putting someone on a NOAC, or something that's going to make them bleed, But it's just culture and habit, because people, use this stuff like tap water, so you're pretty comfortable doing it. But bring in something new, it's like, whoa, wait a minute, what are you doing now?
Right.
And one of the arguments I've seen actually online is like, well, we need a randomized clinical trial for this. And look, in an ideal world, we'd have randomized clinical trials for everything. But in the meantime, we're having to make these decisions. And that's part of the art of medicine, right? You're taking some of the best available evidence or lack of evidence. You're taking biologic, physiologic plausibility, and then you're weighing the risk versus the benefit. And then you're making a clinical decision. And I see a lot of people like reluctant to shift the needle without a randomized clinical trial. And I think, a lot of this evidence is right in front of us, but I agree, it is a balance. I mean, nobody's coming on here and saying like, you should be giving cyproheptadine and SSRIs to everybody. That's not what we're saying. But, by the time these RCTs come out, how many more thousands of people are going to die? And I understand you could make the other argument, how many thousands of people could we potentially hurt with the medications? Because there's always two sides to the coin. But I think this is where, Farid and I and many others are kind of weighing these risks and benefits and think the benefits are greater than the risks. And so you're just not going to have RCTs for everything.
Yep. Tough times for that. Tough times. Well, Farid, thanks so much for going through this with us. Very, very educational. Lots of food for thought. Hopefully a lot of these paths will become more and more explored in the next few weeks. But I think there's already some practical angles that everyone can take back from this and keep an eye out. And certainly, I'm going to include inducible clonus in my routine exam of the COVID patients now.
Yeah, my pleasure. Thank you for having me.
Thanks, Salim, as well.
Thank you. Yeah, thank you. I'm always honored when you ask me to do stuff like this. And Farid, we need to meet in person when it's safe to travel.
Yes, of course. I'd love to, man. Thank you.